Okay, so tonight we're going to talk about CSF and blood supply. And I think, I say this a lot, but I think this is pretty high yield material, especially for any clinical practice. And I think that you're going to find that you actually already know quite a bit. You know more than you may realize. I mean, if you stop and think about it, you've learned an awful lot this semester. We've gone through a lot of material. And in a way, we've just scratched the surface of neuroanatomy, right? But when we talk about CSF and blood supply, we talk about how it affects different parts of the nervous system. And you already know a lot about what different parts of the nervous system do. So you can kind of surmise what's going to happen if you have a stroke that affects the right parietal lobe or the left frontal lobe, and so on and so forth. So you might know more than you realize. And I guess my goal tonight is to kind of pull it all together so that you can take that and go out there and help people out there in the world. Again, that's my fantasy, that I'm doing good through you by teaching you how to go out and help other people. So, okay, in this lecture, we'll discuss in general the structure and functions of the brain's vascular and ventricular systems. Concepts, I like to always go through this just verbatim. The vascular and ventricular systems are concerned with moving fluids, blood and CSF, through the brain, and blockage of or damage to these systems leads to pathology that can often be understood in terms of known anatomy. So you already have a lot of the tools that you need to understand this stuff, but we need to talk a little bit about cerebral vasculature and CSF flow. We'll spend more time on vasculature and quite a bit on the venous systems. So learning objectives. We want to become conversant in the major vessels to and from the cranium, become conversant in the major dural venous sinuses and related structures, understand the arterial feed to and venous drainage from the brain. We want to understand the epidural and subdural potential spaces, understand the subarachnoid space. We want to gain familiarity with the middle meningeal artery, which is the main culprit in epidural hematoma. We want to gain familiarity with bridging veins and subdural hematoma. They're kind of the main culprit in that. And then gain an introduction to the ventricular system. And then, of course, I have the usual key terms. So you want to start learning these like yesterday, because you know how it goes, that it just takes more time to learn vocabulary than it does to learn math, for example. So at any rate, let's continue on. A brief introduction to the meninges and dural venous sinuses. Okay, so again, so here we're looking at, the meninges, you probably learned at some point that they're trilaminar, or maybe you didn't learn that. One of the challenges of this course is that I've had, in the past, I've had everything from MDs to high school students in this course. So I've, high school, undergrad, grad, medical doctors, and they're all here for different reasons. And so I have to try to, appeal to all of those different, skill sets and knowledge bases and so on. So at some point you may have learned that the meninges is trilaminar. It's a little more, there's a little more to it than that. But that's basically correct. Here we have the meninges, they occupy this line around here that's being drawn around the inside of the skull. That's sort of the line that would describe the dura mater right there. Now going into the skull from outside inside, we have to go through the scalp. Do you know the mnemonic for scalp? So it's skin, connective tissue, aponeurosis, loose connective tissue, and then periosteum. Scalp, that's the mnemonic, if you want to know all of these layers. So going through that way, skin, loose connective tissue, aponeurosis, skin, connective tissue, aponeurosis, loose connective tissue, periosteum. And then we have the outer bony table of the skull. And then you have this inner part, that's the diploi, and there are veins that run through there too, diploic veins. Then you have this inner bony table. And then you have the dura mater, which is actually bilaminar. There's a periosteal layer of dura mater and a meningeal layer of dura mater. And then we have arachnoid mater, and that's spelled correctly, by the way. And then we have the subarachnoid space, and then pia mater. And the pia mater is unlike the other two. You know, the dura mater lays against the skull. The arachnoid follows more or less closely with the dura mater. And then the pia mater is the only one that goes down into the sulci and follows the sulci and gyri closely throughout the brain. So yeah, there's again this periosteal layer of dura mater and a meningeal layer, and they go all throughout the cranium, but they end, the periosteal layer ends at the foramen magnum, and the meningeal layer continues down through the spinal canal. It's kind of surrounded by fat, and then the spinal cord is inside of the meninges. You know, it has the same 3-layer meninges as the brain does, minus the periosteal layer of the dura mater. So yeah, this is important. Sometimes people will talk about the so-called epidural space, which would be epi, it's beyond dura, so it would be the space between the dura mater and the skull. Do you see any space there at all? No, of course not. There's no space there. It's a potential space. So you need to understand that. That's a potential space. And sometimes, you know, a hematoma can dissect out that space. And so we'll get into the dynamics of that. It's really important because the dura mater is kind of loosely attached to the skull, except at these sutural lines. You have a coronal suture where bones meet. So there's a coronal suture that goes this way, the sagittal suture, a squamous suture, a lambdoid suture. There are these other sutures. And at those points, the dura mater is tightly adhered and it constricts blood flow if you have an epidural hematoma. And that's clinically relevant. That's very clinically important. And we'll get into the why of that in a bit. So likewise, you have a potential subdural space where when you have subdural hematomas, it's not constrained by internal suture lines though. Yeah, and I've already talked about that. So let's continue on. So here we have the falx cerebri. The falx cerebri. It's a falciform extension of the dura mater. It's a falciform refers to the shape. It's blade-like. There's a type of sword that's called a falchion, and it's a very curved sword. And it has like a spine on it, and then it has a, you know, the other side is sharp. It's not like a double-edged sword, and it's, yeah, shaped like this. So this is the falx. So you'll remember that now, right? The falx has that kind of curved shape, and it's very thin, you know, like a sword blade. There are 3 dural sinuses associated with the falx, and we'll come to those in a couple slides here. So a second dural extension spreads laterally, and that makes the tentorium cerebelli. And you've already seen this actually. Remember the tentorial notch or tentorial incisure? The tentorium cerebelli is like, you see it like edge on right here. And this, you know, this is a parasagittal view. It's just off sagittal, right? Just parasagittal. And so you can't really see the tentorium cerebelli. You'll see it in the next slide. So yeah, the tentorium cerebelli separates the cerebrum up here from the brainstem and cerebellum down here. And then going forward. So here we go. Here we have the anterior cranial fossa, where the frontal lobes lie over the anterior cranial fossa. Middle cranial fossa, your temporal lobes lie in there. And then here you can see the intact tentorium cerebelli on the left side, and it's been artistically dissected away here on the right side. So this would be the posterior cranial fossa, which is also the infratentorial compartment. And again, that's where the cerebellum is. And over here you have brainstem, pons, medulla, and midbrain, most of the midbrain. And this is that, again, that tentorial notch or tentorial incisure that we saw earlier in the semester. And remember, you can have conditions where if you have an increase in supratentorial pressure, maybe due to some mass, it could be hematoma or it could be a tumor or whatever. You can have herniation over the tentorial incisure. Yeah, in life, the tentorial incisure presents a rigid, rather sharp-edged passage for the brainstem. and is of great clinical importance. Yes, when you have changes in pressure, like an increase in supratentorial pressure, you can also, this can like cut parts of the brain, parts of the temporal lobes right here. So that's what kind of gets herniated across it. Remember that the uncus gets herniated across, and it can actually cut the uncus, it can damage it, but more commonly it puts pressure on cranial nerve 3. This is cranial nerve 3, the oculomotor nerve. Here it is on the other side. And you know what happens then. The eye goes down, out, dilated pupil, drooping eyelid. So here's that image. I was 2 slides previously, and now we can see the dural venous sinuses that I alluded to previously. And these dural venous sinuses are part of the venous system, but they're a little bit different in structure. Typical veins have this trilaminar structure. Typical vessels have a trilaminar structure. But the dural venous sinuses are actually made out of the dura mater. They're these places where you have spaces in the dura mater. So we'll get into that in a little more detail in a minute. But here we have the superior sagittal sinus running right there at the top of the falx cerebri. Runs like that. We have, of course, an inferior sagittal sinus right here. That's labeled over here too. And then that kind of comes around and dumps into the straight sinus, which, and we'll come back to it. And then we have a sigmoid sinus here, a transverse sinus here. Sigmoid is S-shaped, right? And the transverse sinus empties into the sigmoid sinus, which then empties into the jugular, though it's not labeled here. Over here, we have a smaller occipital sinus. I've seen all this anatomy a lot in cadavers, and I've dissected this a lot. And I want to say, there's a lot of anatomical variation. There's a couple main variants on this confluence of sinuses back here. So typically the superior sagittal sinus will empty into the right transverse sinus. Sometimes it empties into the left. Typically, the straight sinus commonly will empty into the left transverse sinus. You have variations on all this stuff. Sometimes there's a confluence where everything comes together. Sometimes there isn't. It can empty this way or that. And it could have clinical implications. So going forward, this is an image that we'll use. I think this appears 3 times tonight, and we'll label different structures on it each time. So here we want to talk about how the dural venous sinuses are formed. So again, remember, though you've heard that the meninges are trilaminar, the dura mater is actually bilaminar. So it's more complicated than just a 3-layered meninges. I don't want to overcomplicate it or overplay that, but it's important here because here we have the periosteal layer and the meningeal layer separated out. And you can see that, they're tightly together throughout most of the cranium, and you couldn't pull them apart. And by the way, the dura mater is really tough. It's aptly named. Dura is the same word root as durable, and it is in fact that. It's really, really tough. It would be difficult to tear it in most places. There are places where it gets thin and you might be able to tear it, but it's pretty tough. But it sort of naturally delaminates in places like here in this, we have this coronal view, right? You can see the ear there, coronal view, and this part is blown up over here. And the dura mater is following the inside of the skull, but it delaminates here to form the superior sagittal sinus. That's what that stands for. It delaminates, goes down, forming the falx, and wraps around forming the inferior sagittal sinus. It comes back around and relaminates with itself, goes back up and it relaminates with the periosteal layer over here. So this is all the meningeal layer, right? And it delaminates from and relaminates with the periosteal layer of dura mater to form these dural venous sinuses.
Dr. Rowe?
Yeah.
Is this the case for every deep fissure? So we're talking about the central fissure here. But what about the one on the right there? Do these sort of structures where the dura mater sort of goes into the fissure, are they repeated elsewhere along the brain?
Well, let's go back just briefly here. I'm sorry, wrong direction. So I'm not sure if I'm understanding your question, but all of the venous sinuses, the straight sinus, transverse, sigmoid, all of these are made the same way. But the
Right.
dura mater doesn't go into the lateral fissure, for example, if that's what you're asking.
Yeah, that's what I was asking. Okay, so
Okay.
we have the sinuses, but without the dura mater sort of indenting itself into the other fissures. Okay.
Right. The lateral fissure would be, so the temporal lobe would be about here, so the
Yeah.
lateral fissure would be about there, and you can see the dura mater just goes over it. Yep. Fair question. So, okay, continuing on. So same image, different structures are labeled. So we talked about the dura mater. Here's the arachnoid mater, and it follows along with the dura mater in most places. And then it goes around like this. We'll talk about these arachnoid granulations in a bit. Yeah, here we have AT, or arachnoid trabeculae. They're over here. They're somewhere over here. Oh, there it is. Arachnoid trabeculae. That's a fancy word, right? They're these little polymeric structures, polymers, right? They're just these repeating motifs, and they're string-like, polymers that connect between the arachnoid mater and the pia mater. So they sort of traverse the subarachnoid space here, and you have in the subarachnoid space, you can see here a lot of arteries. Those are red arteries, and you also have veins in the subarachnoid space. And any of those can, form an aneurysm, for example. The aneurysm can rupture. You have a subarachnoid hemorrhage. We'll talk about that one briefly tonight. The pia mater, again, is the only meninx that closely follows the surface of the brain. Meninx is singular for meninges, by the way, if you didn't know that. It's a good word to have in your vocabulary.
Dr. Rell,
Yeah.
is the arachnoid trabeculae, is that formed similar to the trabecular meshwork around the eye? Is that why they call it that?
I think it's referring to the same structure. They're just web-like structures.
Oh, okay.
That's kind of how anatomy terms work, All right, so I think I covered everything I want to cover here. We'll come back to this image again in a bit. So strokes, clots, and aneurysms. So these two slides here have a lot of terms on them. I'm going to go through some real quickly, and some I'll spend a little more time on because they might be concepts you haven't heard of. So aneurysms are, in here we talk about fusiform aneurysms and saccular, and we describe them by morphology. But I want to be clear, I think I should maybe rewrite this definition of aneurysms, because there are other ways to describe aneurysms. Like sometimes an aneurysm will dissect these layers, like a dissecting aneurysm will dissect between the intima and media layers of vessels. But in here we talk about fusiform and saccular. Fusiform is like the shape of your biceps, for example. It has that torpedo-like shape where it's fat in the middle and then skinny. And sometimes you will just have a swelling in an artery, or it can be a vein. More commonly arteries, but you can have just a swelling, and that swelling can get bigger and bigger, and it can rupture, in which case you have a ruptured aneurysm and it bleeds out. And that's a big problem, of course. So fusiform is one morphology, and saccular is the other shape that we talk about. And saccular aneurysms are circular, like a sac. Sometimes we call those berry aneurysms because they look like a berry. Question. Atherosclerosis, I have something to say about this. I've dissected a lot of cadavers, and I've seen a lot of atherosclerotic plaques. Cadavers are commonly older because, people decide to give their body to science, and then, they live their life and they die, usually of coronary disease or something like that. And so, yeah, but by the time people are in their 7th or 8th decade, it seems like these atherosclerotic plaques are just all over the place. I've seen so many of them. And some brains are just like, plagued with these. But these plaques composed of these things: fat, cholesterol, calcium, and they build up on the insides of arteries. causing a stenosis, narrowing the artery. Remember that word stenosis, we've come across that before. And then when you narrow arteries, and what happens, you constrict blood flow and limit the supply of oxygen and nutrients to tissues. That's a problem. Embolism or embolus. An embolus is just like a blood clot or an air bubble, anything moving through vessels, but they typically get lodged in vessels, right? And block it and cause ischemic attacks. And that can lead to an infarct or death of tissue. Thrombus, blood clot that forms in a vessel and just lodges there. Ischemia, I just mentioned that. So restricted blood flow, and you know this one pretty well. We've seen this before this semester. You can have an ischemic stroke, which is just a loss of blood flow, which leads to hypoxia or an anoxia, reduced oxygen or no oxygen. Hemorrhage, just a bleed out, like for example, a ruptured aneurysm can bleed and hemorrhage. Now this one you might not have guessed, you might not have known about. So after like an ischemic attack, for example, when blood re-enters the tissue, you can have what's called a reperfusion injury. When it comes in too quickly, there's this whole chemical cascade. I know I say that a lot. There's hand waving. So I just want to be clear about that. But yeah, when you have return of blood supply, it's not just a simple like, yay, everything is fixed. You can have reperfusion injury in which circulation results in oxidative stress and inflammation. Remember, the inflammatory response is another one of those chemical cascades. It's really complicated. Transient ischemic attack, you've probably heard of that one. Just a quick stroke that resolves quickly without infarction or without clear infarction. I can't imagine it's good for a brain, right? But there's no clear evidence of infarction in TIAs. And then finally, this concept of watershed area. It's kind of an important idea. It's a big idea. Strokes happen a lot in watershed areas. And these are areas where different arteries, where different arterial feeds meet. So like, for example, the middle cerebral artery feeds the lateral aspect of the cerebral hemispheres. And then the anterior and posterior cerebral arteries kind of get the sort of this part of the cerebral hemispheres, like the middle, the medial, and like just around like the parasagittal portion of the cerebral hemispheres. And so right where those two areas meet, the area that's fed by the middle cerebral artery and either the anterior or posterior cerebral arteries, where those arterial feeds meet, we call those watershed areas. So those are areas that receive dual blood supply from two major arteries. And so watershed strokes are concerned because they comprise about 10% of all ischemic strokes. So I want you to have that concept under your belt there. And now you do. So yeah, here's just a nice slide from this source down here. Shows again a saccular aneurysm. You can see why we call it a berry aneurysm, but you wouldn't want to eat this berry. There's a fusiform aneurysm right there. A ruptured aneurysm, it's a bleed, it bleeds out. Blood clot, atherosclerotic clot or plaque. And then here are types of strokes over here. We just covered that, but there's another image for you if that helps you get it in your head. So now let's get oriented. You know what you're looking at over here, right? I mean, this is the ventral surface of the brainstem. And here we have the medulla. And here we have the pons. This is pons. The medulla meets the pons. And then pons meets the midbrain up here. So that's midbrain. And then down here we have labeled over here the basilar artery, posterior communicating artery, middle cerebral artery, anterior cerebral artery, and the anterior communicating artery. And over here is, on this side, this is the vertebral artery. And these vertebral arteries ascend like the ventrolateral aspect of the medulla and come up and form the singular basilar artery here, which goes right up the ventral medial pons to the circle of Willis, right? And then we have these other arteries here. We'll come to these in a minute. But look at this. Sometimes we have what's called a top of the basilar berry. top of the basilar berry aneurysm. So these are saccular aneurysms or berry aneurysms on and around the circle of Willis. So this is the circle of Willis. Here it's outlined. And this is like incidence of different types of aneurysms. They're not super common, but they're common enough that they're noteworthy. Top of the basilar berry. You can have, you know, berry aneurysms here, here, here. They happen all around the circle of Willis. Remember this image? We saw this image earlier in the semester. Again, that's a berry aneurysm. That's which cranial nerve is that? I should ask you. Which cranial nerve is this, folks? You know this. Right there. It exits between the posterior cerebral and superior cerebellar arteries.
Optic?
It's the cranial nerve that if you put pressure on it, it causes the eye to depress, abduct, into
Optic.
Oculomotor.
oculomotor. You got it. Good. You're sharp. Yeah, some of you got it. Alma got it. Jessica, good job. So yeah, we've seen this before, but that's a clinical correlation there that we've seen. And I see over here, Luke says, in prior EMT training, I was taught and suspected abdominal aortic aneurysms were good reason to get to the hospital ASAP. Absolutely. Yeah, Luke says, I felt it on a patient's abdomen by palpating lightly. Interesting. Love when you bring that stuff to my class, folks. So blood vessels in the meninges, part 1 of 2. Okay. So, all right, the meningeal arteries. So the most important meningeal artery by far is the middle meningeal artery. These meningeal arteries are sort of, I've seen them quite a bit, and they go like along the sort of the outside of the dura mater, between the dura mater and the skull, but they're like attached to the dura mater. You couldn't just pull them up. So we have this tiny bit of the dura mater that's fed by the anterior meningeal artery, this tiny bit that's fed by the posterior meningeal artery, and then this great big area, like the bulk of the dura mater is fed by the so-called middle meningeal artery and all of its many branches, its many unnamed branches. And so it's the most important clinically by far. And this is the culprit in epidural hematoma. Somebody gets hit in the head, for example, they're in a car accident, they get hit hard in the head, they crack their skull, they have and then like depresses, maybe a depressed fracture, cuts, the middle meningeal artery, one of its branches, dissects the middle meningeal artery, to use a more technical term, and it bleeds into the epidural space, the space between the dura mater and the skull. So, maybe you heard when you were a kid. I remember when I was a kid, I was told by one of the bullies on the playground, I could hit you right here so hard I would kill you, and that's not too far from truth. That can happen, and I'll explain sort of how that happens in just a minute here. In fact, this is the start of it. So this part right here, so we have the frontal bone, just like the frontal lobe, parietal, occipital, and temporal. Well, here's the frontal bone, parietal bone, occipital bone, and the temporal bone. And so where all these bones meet right here, you have a spot that we call terion. It's labeled right there, terion. And because all of these bones meet there, the bones, you can, if you can get a purchase on them, if you can get a good grip on them, you could actually pull them apart. But so you have this spot here that's relatively weak because it's where all these bones meet and they're not fused real solidly. These like sutural lines kind of disappear as we age, by the way, because they kind of fill in. I've seen this a lot. As you age, they kind of fill in. But anyway, so yeah, terion is kind of a place of relative weakness. And here it's labeled there. And if you follow this line over, that's terion. This is the middle meningeal artery coming through, pencils down moment. It comes through a hole called this foramen spinosum right there. It's going up and feeding the dura mater here, middle meningeal artery. You see all the branches. And you can see that branches are proximal to pterion right there. And then down here, you have middle meningeal artery labeled. This is the middle meningeal artery. And here we have a skull fracture. And in this case, we pretend that the fracture like was depressed and then pushed back out for whatever reason. But the fracture like ruptured the middle meningeal artery, which bled into this potential space between the skull and the dura mater labeled there. So bled into that potential space, and this is what happens. You have a big bleed there. Of course, you can read all of these details on your own. Don't read along, just listen to what I'm saying. Look at this. Look at this. This is a sick, sick brain. I look at this and it's kind of distressing, you know? This is an incredibly sick brain. So let's look at it 3 different ways here. Here we have imaging, like a transverse section here. And you can see the lens shape of this epidural hematoma. That gives away that it's an epidural hematoma, because what's happening is that you have a sutural line here, a sagittal sutural line, and then you have a coronal suture this way, okay? And so it's keeping that hematoma constrained within those sutural lines. You can see it over here. So this is a coronal section through the skull and through the brain. That's the sagittal suture there. And remember, those are the places where the dura mater is tightly adhered, right? So yeah, this is the squamous suture over here. You don't have to know that. It's just, that's what we call that suture. And so the dura mater is adhered there, and it constrains where this hemorrhage can go. So the problem with that is because it can't spread around, it just pushes deeper and deeper into the brain. And so that's a serious problem. And you know, if you have a bleed, if you have a rupture of some part of the middle meningeal artery, and it's, you know, dissecting this potential space into an actual space and pushing deeper and deeper into the brain, you know, the symptoms can develop relatively quickly. And, you know, you can lose somebody within, easily within, you know, minutes to hours. So they need to get straight to the ER, right? And then down here, we have a brain. Look at that. That's incredible. This is parietal over here. So this is, if you can't tell, anterior, posterior. And so this epidural hematoma was constrained into the parietal area. And just look at how it depressed that brain. And presumably this is what killed this person. I say presumably because sometimes you see things like this. You look at the cause of death and it says heart disease or something. You're like, what? Believe me, I've seen that sort of thing. But yeah, hematomas of this sort cause rapid increase in intracranial pressure, necessitating emergency surgical intervention. Maybe you've heard of this practice of trepanning, of making holes in skulls, and many ancient peoples did this, and they probably did it for different reasons. But we think that some of them probably did it to relieve this sort of pressure. And we know that some people survived this process because we've seen trepaned skulls with bone that regrew, like bone regrowth in these.
So, Dr. Earl, I guess I'm a little confused at what I'm looking at. Is that the concaveness there, is that because those cells died, or because...
Here?
Yeah.
Okay, so I think what we're looking at here is that there was, well, this is like a convexity. So I guess that this side is concave, we would say. I see what you're saying. And so I think what we're looking at is that when this person was perfused and then fixed, I think that that process kind of cross-links proteins and makes everything stay at whatever shape it is.
I see.
So, yeah.
Oh.
So this is our epidural case study. Do you know what this is from the poem, right? So this is our clinical vignette by Randy, and this does not end well as well as the poem. The poem is not happy, but this vignette is even less happy. The mighty Casey steps up to bat. There's the windup and the throw. It's a wild fastball that's high and that's inside and high. Casey reels backward, but the ball slams into his left temple. Casey regains his feet, but soon feels dizzy and is taken from the field to a nearby hospital where he's seen in the emergency room. The initial examination reveals that he's awake and responsive, but he soon begins to lose consciousness. A quick examination of his eyes reveals that the left eye is deviated downward, outward, and has a dilated pupil that does not react to light. Which cranial nerve is implicated? You know. 3, right? That's the oculomotor nerve. So that's the effects on the oculomotor nerve. In addition, papilledema is noted in both eyes. Remember, the optic disc gets pushed out. It's like effaced. And so you no longer have a sharp optic disc, but like you can't see sharp borders like you normally would when you look at it with a fundoscopic examination. So over the next 20 minutes, his breathing becomes erratic, his heart rate decreases, and within an hour, he's pronounced dead. Sad. Postmortem CT reveals a well-circumscribed lens-shaped density in the left temporal region that's confined within sutural boundaries. So it's around here, right? Confined in sutural boundaries. Cause of death, compression of the brainstem, secondary to epidural hematoma. So what are we looking at in this image? It's kind of nice. It's a lateral view of the skull, and you have the frontal, parietal, occipital bone back here. Temporal bone is color-coded yellow. And then this is the sphenoid bone. It's a beautiful bone. I guess it's considered the most complicated bone in the head. They're beautiful. So yeah, right there's Terrien, and you can see that we have drawn in here where the territory of the middle meningeal artery would be. So you can see that Terrien lies right over branches of the middle meningeal artery. And that's the problem. Mighty Casey got hit right there around Terrien, and it dissected his middle meningeal artery, and he suffered an epidural hematoma and died.
So Dr. Rowe, just a quick question if you don't mind. Wouldn't the cortical symptoms appear first because the compression begins at the cortex and goes towards the brainstem? I'm just thinking that maybe Broca's area is somewhere in that vicinity.
Well, no, I think it's a good question, but what we're looking at here, so Broca's area is more like about here, and this is contained within sutural lines. So the hematoma in this case is more like,
oh, so it stays in that area rather than spread to where Broca's area is.
Doesn't really, well, you know, it's kind of down in this area and putting pressure on the brainstem. It's kind of, I'm making it up, but I think that's sort of the sense of this clinical vignette.
Okay.
Yeah. It's a fair question. But this COD was compression of the brainstem, secondary to epidural hematoma. So, yeah. And of course, clinical case courtesy of Randy, who I miss. Yeah, Terrien is the same as the temple. When people say, oh, I hit you in the temple or whatever, it's the, yeah, temple area. All right, so here's that image again that we saw previously with a different kind of key image. And so here we're talking about the dura mater. Here you can see the superior sagittal sinus. And then, yeah, here you can see a bridging veins. I don't know how well illustrated it is in this Netter illustration. I love Netter, but you have to imagine that there's the arachnoid mater here. So you can see kind of that glistening, imagine a glistening arachnoid mater. And then these bridging veins will punch out of the arachnoid mater into like the subdural space here, bridging vein. They really just run a short distance. And it's well illustrated over here where you have an arachnoid mater in a coronal view. And here's a bridging vein that bridges between the arachnoid mater and the superior sagittal sinus. And so these veins like carry blood into the superior sagittal sinus. But what will commonly happen, and this happens a lot in elderly, deceleration injuries, right? Like car accidents, rapid deceleration. And for whatever reason, they will cause a rupture of the bridging veins here, and then there's a bleed into the subdural potential space, creating an actual space. And then the clinical course is not dissimilar to the epidural hematoma, but it takes a little longer for things to develop because this hematoma is not constrained by sutural lines. You know, here's the epidural, right? This is all epidural, beyond the dura. Subdural down here, it's not constrained by sutural lines. So note that there are numerous superficial cerebral veins. Yeah, and they ultimately drain into the dural venous sinuses. Yeah, I think I said all of this. Okay, you can go and read the text on your own. Okay, so again, here are the bridging veins labeled right there. Bridging vein, bridging vein, bridging vein. You know, here they would just be like cerebral veins, and then we call them bridging veins at these points. And so here you have the dura mater. You have a bridging vein has been ruptured, maybe due to a car accident or some blow to the head. And it's ruptured and it bleeds into the subdural space, forming this great big hematoma, right? And so here's what it looks like on imaging. Again, it's different than what we saw previously with epidural hematoma. It's not confined by sutural boundaries. So it has this like crescentric shape. It's a crescent shaped. Well, look at this. Let me point something out here in this axial view. Anterior, posterior. What looks just distressingly wrong about this? If I draw this, this is like midline, right? That's midline. Look at that. Look at how structures are deviated way off midline. That's really alarming. This is part of the falx cerebri. You can see it's kind of deviated slightly to the right. This is where the lateral ventricles meet up, and it should be like this point should be about right there. So this is a big problem. You know, this is putting a lot of pressure on the brain. It's really increased the supratentorial pressure. So that's what's being talked about down here. Midline shifting, herniation of structures is always a possibility. Not just the uncus, but other things can herniate too. And we'll talk about that in just a bit. I know we need to take a break in a minute. We'll get to it. So here again is a subdural hematoma in imaging. Here it is in this nice illustration over here. And I wish I could source this illustration. It's beautiful. But you can see, as opposed to like the epidural was constrained between these sutural lines, this is just kind of spreading all over. And so it progresses a little bit more slowly. So the area of bleeding is not constrained. Laceration of bridging veins is the common cause. And bridging veins connect the blood supply at the surface of the brain to the dural sinuses. And this might occur in like motor vehicle collision, car crash, right? It's terrible. And it's particularly common in the elderly. So going forward, so we need to go just a few more minutes and then we'll break after a short video. So we're going to go through this vignette, then we'll do a short like 3-minute video that I'll narrate because, you know, I like to dominate my class. I should. So, okay, so Aunt Minnie, this is a pun too, because an Aunt Minnie on radiology is a definitive sign. So that's why this clinical vignette is named after Aunt Minnie, courtesy of, again, Randy, my colleague Randy. So Aunt Minnie is 83 years old today. As she stood up to get out of the dental chair, she stumbled on the floor mat, causing her to fall and hit the right side of her head against the side table. At first, she seemed fine, but over the following 3 days, she began to notice strange burning and tingling sensations in her left arm. So a lot longer course than Mighty Casey, okay? So maybe we exaggerated that for effect, but it's a longer course of progression. So she noticed weakness in her left hand, implicating right hemisphere involvement, remember? So her son dropped by and decided to take her to the doctor. A quick neurological assessment revealed weakness at the left arm, accompanied by paresthesia. There was a flattening of the left nasolabial groove and some drooling of saliva from the left labial commissure. These are all signs of right hemisphere involvement because it's all left hemisphere paresthesia. Her speech was slow and disordered with multiple use of verbs accompanied by pauses and word searching. Okay, it's right hemisphere, so that's a little more difficult to explain, but you can ask me after class. At the hospital sometime later, a CT revealed a right-sided concentric density. So that's what we're seeing here, because remember, we're looking toe to crown, so this is the right side over here. A right-sided concentric density that closely followed the internal contours of the skull, stretching across suture lines. It's concave toward the skull while convex on the side of the brain. This is a typical presentation of subdural hematoma, and that's what's being illustrated here. Ruptured bridging vein, bleeding into the subdural space. That's dura mater right there. Skull, dura
Dr.
mater.
Rowe, you said that for the scans, the lighter regions are higher density or lower density?
Higher water content. This is blood over here.
Okay.
Subarachnoid hemorrhage and aneurysms. We probably don't spend as much time as certainly as much time as I would like to on subarachnoid hemorrhage. What just happened there? Sorry, I have to go back. There we go. So yeah, subarachnoid hemorrhage. You know, yeah, the circle of Willis is at the base of the brain. It's supplied by the internal carotid arteries and the basilar artery, which is supplied by the vertebral arteries. So the cerebral arteries course over the surface of the brain. Sometimes they form aneurysms, and they're like in the subarachnoid space. And, you know, you can have ruptured aneurysms, which generally, you know, commonly like bleed into the basal aspect of the skull down in here, the cranial vault, if you will, the basal aspect. So we have a lot of blood in the subarachnoid space, in this instance originating in the chiasmatic cistern. So that's around here. It's not well illustrated here. But it's a big problem. There was actually a doctor at BI had this problem recently. Of course, I won't say who, but they had a subarachnoid hemorrhage and were unconscious for a while and made a really good recovery, but you know, it's tough stuff. One problem is that, believe it or not, what's illustrated over here, we have an aneurysm, a ruptured aneurysm, leaking blood out. So we have a blood clot, and that can cause vasospasm because blood belongs on the inside and not on the outside. So there are neurovascular irritants in blood that can actually produce vasospasm, causing additional like ischemic events downstream, right? So, and then here's a subarachnoid hemorrhage on imaging, and all of these white spots, especially like around here, or where you have blood. So, and sorry, I don't have a good clinical vignette for that, but we do have this. You know, we talked about uncal herniation, remember? And here we have a coronal dissection of the brain with the dura mater intact surrounding the brain. So there are a number of other ways that brain structures can herniate. For example, suppose you have a bleed up here. This looks like hematoma. It can cause, here we have the cingulate gyrus, and it's causing a subfalcine herniation. The cingulate gyrus is herniating under the falx cerebri, and it's weird. It can like scrape over the cingulate, and I always say like a knife over burnt toast. You know, you burn your toast and you scrape your knife over it. You can end up with what's called a decorticate lesion, which just scrapes off a portion of the cortex here. You can imagine that happening. It's a serious problem. Central herniation is illustrated at number 2 here. So you just push central structures down toward or through the tentorial incisure, which is not labeled here. Uncal herniation, we've seen that. That's herniating over the tentorial incisure. There's a tentorium cerebelli, and the opening is the tentorial incisure, so-called. And so, yeah, you can have the uncus of the medial aspect of the temporal lobe herniate over that, and it commonly puts pressure on cranial nerve 3. Here is illustrated a tonsillar herniation, like the cerebellar tonsils. You know, similar to like those Chiari malformations. Remember that way back from the beginning of the semester? Here we have tonsillar herniation, where the cerebellar tonsils are herniating through the foramen magnum, which is not labeled here, but you know it's right there.
Dr. Rowe, is corpus callosum function impacted by this in any way?
I can only imagine that the answer is yes. I can't give you a precise example of that, but yeah, would probably have to be. I made a big mess over here. I'm distracted by it. Sorry, folks. Spilled my tea. Okay, so yeah, continuing on. Yeah, you can read all of this, of course. Those are the main points. You know, this whole bit about oculomotor ophthalmoplegia. You know that one well. So you're going to see that again. And this slide, you're already familiar with this. You know, if you have an increase in supratentorial pressure, oftentimes, look at this. Here we have the optic nerve, and this is the eye, like the back of the orbit. This is optic disc right here. It's not labeled as such. But you have surrounding the optic nerve, pia mater, labeled here, arachnoid mater. You have CSF in the space between the two. You have dura mater, which, remember, it just continues on, just continuous with the sclera, right? And so when you have an increase in supratentorial pressure, or you have an increase in CSF in the subarachnoid space, and that's effacing the optic disc. And so this is a normal optic disc here with nice clear boundaries. And this is a papilledema. This is when you have an optic disc that's indicative of increased supratentorial pressure. And you would detect that with fundoscopy, right? So continuing on, we've actually seen this slide before, so I'm just gonna skip it. It's from earlier in the semester, I just didn't cut it out. It's probably good to have in here though, you know, it comes up again. So now we wanna talk about the superficial veins of the head and neck. So some superficial veins of the scalp and face, including deep veins of the orbit and infratentorial fossa, are interconnected with the dural venous sinuses by way of emissary veins. So maybe at some point you heard that, you know, the blood supply to the intracranial compartment is separate from extracranial, and that's mostly true, mostly, right? Not entirely. There are cases where you can, you know, have an infection of the scalp and it ends up inside of the cranium. And we're gonna look at how that can happen. Note, the following venous channels are clinically important because they are mostly valveless. You know, veins of the head and neck kind of don't need valves because gravity helps blood to drain. It can be a clinical problem. So yeah, here we have superficial scalp veins that course all over the scalp, you know. Sometimes they'll punch through the outer bony table of the skull, and then they'll travel around this way and that in the diploe, you know, the spongy portion between the two tables of the skull. We call these diploic veins, you know, they're just aptly named. And then once in a while, one of those diploic veins will punch through the inner bony table of the skull into one of the dural venous sinuses. And so this is a pathway for infection. Fascinating, isn't it? This is one more thing for you to worry about. Again, remember that virtually all of these venous channels are valveless. So infection can travel either way. Here we have, again, another coronal section. This is the superior sagittal sinus in a cross section in a coronal view, right? And here we have an emissary vein that's drawn here, just going from the scalp straight into the superior sagittal sinus. Here again, these are very common. They're inconsistent, but these emissary veins, these parietal emissary veins, they'll sometimes be on one side or just one side or the other side, sometimes both sides. Sometimes they're really small, sometimes they're huge. There's all kinds of variability. Here's another emissary vein over here. They're pretty common. There are a couple of places where you have these emissary veins. And so we're gonna see this, maybe you've heard of this concept of the danger triangle, right? This part of your face. You know, I mean, there are cases where people had a pimple over here worst pimple ever, like a comedy skit, you know, and they pinch the pimple, and it drives the infection into a vein, and it ends up going through an emissary vein. You know, there are a couple emissary, an infraorbital vein, supraorbital vein. They connect to the cavernous sinus inconsistently. Depends. It's inconsistent between people. I know this from cadavers, but that's one way that an infection can get into the cavernous sinus, which is located deep to about that point right there. We'll see it again. So again, deep venous structures of the face include the pterygoid plexus. This is the pterygoid plexus here. And this is never preserved on cadavers. You never see it. It just like, it all gets torn up as you're dissecting into this area. Just an FYI. But look at that. There's an emissary vein. Here's another emissary vein. Here's another emissary vein. They're, again, kind of inconsistent. Some people have them, some people don't. Sometimes they're big, sometimes they're small. Here again is the cavernous sinus that I was talking about previously. And the optic chiasm, there's the optic nerve, so the chiasm would be about there. And the cavernous sinus lies on either side of the chiasm. So yeah, the infraorbital vein is entering the infraorbital foramen here. So that's one route for infection. That's another route for infection, the superior and inferior ophthalmic veins. So, you know, that's why this danger triangle is dangerous. Here's the vein of Vesalius. And again, that's inconsistent. And that's drawn in here artificially, by the way. This is Netter's illustration, but Randy and I drew this in. Randy drew it in, and then I did some more work on it. Can't even tell, can you? So here's Fred, another clinical vignette. Bacterial meningitis. Ooh, ah. So here we go. Fred was walking through the woods when he accidentally bumped his head against a low-lying limb. Unfortunately, this limb was one of those with thousands of ugly 1-inch thorns, black locust, I think. And being a puncture wound, it did not heal too much. And the more Fred rubbed it and scratched at it, the less it hurt. You know how that goes. So, however, Fred was unaware that the tip of the thorn had broken off and was still lodged deep in his scalp. With the pain all but gone, Fred continued his walk and returned home. Why worry about it, you know? So the following day, Fred noticed a gentle swelling over the vertex of his skull, but paid little attention to it, because why worry? 2 days later, Fred began to have a headache that no over-the-counter medication would reduce. That's frustrating and perhaps alarming. The next day, Fred reports to his wife that he feels horrible and is running a fever with a temperature of 102.3 degrees Fahrenheit. Okay. Fred is taken to the urgent care center. That's appropriate. Where the following additional observations are made. Generalized malaise, photophobia, sensitive to light, phonophobia, sensitive to sound, pronounced nuchal rigidity, neck rigidity, right? After ruling out papilledema, a lumbar puncture is performed and the CSF analysis reveals a high white cell count. He has an infection with polymorphonuclear predominance, high protein, and lower than normal glucose levels. He has some kind of infection, bacterial infection, in fact. That's a bacterial meningitis, typical presentation. Meningism is this triad of photophobia, nuchal rigidity, and headache that we see in Fred's case. So commonly seen in meningitis, subarachnoid hemorrhage, and other diseases. So yeah.
So ruling out papilledema rules out stroke generally?
It just means that you're safe to do a lumbar puncture. So going forward, this is a reference slide. You're quite familiar with all of this by now. Frontal, parietal, occipital, temporal lobe, no problem. So let's talk a little bit about the arterial supply of the brain. The following series of slides introduces us to the arterial supply to the brain. And as previously mentioned, the cerebral arteries are located in the subarachnoid space. This has clinical consequences like for subarachnoid hemorrhage. So most of the structures in the following slides are shown repeatedly. So yeah, let's pick an artery and we'll follow like the middle meningeal artery, for example. So here we have aortic arch. On the left side, you know, the common carotid comes off, bifurcates into an external and an internal carotid artery. So, and of course, there's one on each side. And it goes on up, does this curious jog at the cavernous sinus. And this is where the circle of Willis starts, right there. So that's the one of two major blood supplies to the brain. The other one being the vertebral artery, which goes up through these transverse foramina of the spine. They're not labeled. It goes up, like jogs around and like punches through the foramen magnum and goes up, forming the vertebral arteries here. Those are vertebral arteries. And then there's the basilar artery, goes up again to the circle of Willis, which is running here. So going forward, I'd like this illustration. So it's like the ventral surface of the brain, of course, anterior, posterior, vertebral arteries on either side, the singular basilar artery right there. Here they're not labeled, but that's labeled. Superior cerebellar artery, posterior cerebral artery, and here's the internal carotid where it becomes the middle cerebral artery. Internal carotid, middle cerebral artery, and the anterior cerebral artery is a branch off the middle cerebral artery. So you can see the middle cerebral artery, let's follow that for a minute. The middle cerebral artery sort of goes between the frontal and temporal lobes, and you can see that here because the temporal lobe has been artistically removed. So going back, let's go back to the previous slide. So that's internal carotid, goes up to the circle of Willis at this point, going forward again. Internal carotid becomes middle cerebral artery, which goes off branching this way and that. Let's follow further. Here again is the middle cerebral artery. Here we're looking from an anterior view. So it's like the person's nose is right here, you know. And so middle cerebral artery, it actually bifurcates. And so here's the middle cerebral artery bifurcating and supplying, branches of it supply the entire lateral hemisphere. Going forward further, no middle cerebral artery, it's cut right there. So we'll go to the next slide. There's the middle cerebral artery coming off the circle of Willis.
Okay.
Some middle cerebral artery right there.
Mhm.
And then going forward, again, middle cerebral artery. And here we have the superior trunk and the inferior trunk. And so you can see that, you know, the superior trunk is supplying blood to all of this area, the inferior trunk to all of this area, including parietal lobe. Like the inferior trunk supplies blood to the parietal lobe, which I think is a little bit counterintuitive, but that's how it works. And so, yeah, let's do one more. Here we have the anterior cerebral artery going forward, anterior cerebral artery. It's supplying kind of the medial surface and out to about here of the lateral surface of the brain. Going forward, no anterior cerebral artery, rather. Anterior cerebral artery coming off the circle of Willis. Well, coming off the middle cerebral artery there, forming part of the circle of Willis. And there again, anterior cerebral artery. And there's the anterior cerebral artery. It supplies all of this part of the brain to about here. And all of this is supplied by the posterior cerebral artery, which has branches off this way. And we even saw that example where, you know, there was an ischemia of branches of the posterior cerebral artery that led to prosopagnosia, right? I don't know if you remember that. Well, so going forward, this is a nice illustration of the territories of the cerebral arteries. So a lateral view, and you can see anterior, posterior, middle cerebral arteries. And of course, this part that I'm tracing is a watershed area. That's all watershed area. It receives dual supply, right, from two major arteries. So here's a medial view, anterior, posterior again. Same as down here, right? Medial view, anterior, posterior, And so anterior cerebral artery, posterior cerebral artery, and then this ventral view shows territory of the anterior, middle, and posterior cerebral arteries. So now let's talk about the ventricles of the brain. I like this Netter illustration. It's like a ghosted view of the ventricles of the brain. You can see the lateral ventricles, the intraventricular foramen here. Third ventricle is singular. It's a singular midline structure. One of few in the nervous system, right, in the brain. Most structures are bilateral. There are a few that are singular. Cerebral aqueduct goes down to the fourth ventricle down here. And then we have some lateral foramen and a single medial foramen that CSF escapes, or apertures we call them. Lateral aperture and median aperture. So here's labeled the lateral ventricles, intraventricular foramen, third ventricle, cerebral aqueduct, all the stuff that I was just talking about in this lateral view. And so here we have a coronal view. And, you know, you have to imagine that this coronal section is sort of through right here, like that plane, somewhere around there. So that you're getting lateral ventricle, like this part of the lateral ventricle down here. And you have choroid plexus throughout. And this choroid plexus is this structure that produces cerebrospinal fluid, which to a first order approximation is like ultra-filtered blood, an ultra-filtrative blood with no big proteins, no red blood cells, no white blood cells, mostly. It's just filtered blood. So anyway, yeah, I'm talking about, yeah. So yeah, CSF is produced in all four ventricles. You have choroid plexus throughout, and then it circulates in generally this direction, escapes the lateral ventricle, lateral apertures, one on either side, or the singular median aperture. And then just a trickle continues down the central canal of the spinal cord. Here we talk about hydrocephalus is an abnormal accumulation of CSF within this system. We'll see some examples of what that looks like here. So this is another illustration. So CSF is produced in the choroid plexus of the lateral ventricles, third and fourth ventricle. And it generally moves in like this direction, moves downward and escapes the lateral apertures, the single median aperture. A trickle again goes down the central canal, as I said previously. But most of it sort of bathes the brain so that the brain is just floating in this about 140 mils apparently of CSF. It's not a ton of CSF, but it's enough that the brain is floating in there and contained within the meninges, which are acting like a sac. That's, you know, so the brain's floating around in there and kind of effectively lightens the brain. You know what happens to beached whales? You know, they suffocate. You know, and if your brain were outside of this, it would just like collapse of its own weight. So it's floating in here, and it generally like circulates up in this direction. And it's reabsorbed in these arachnoid granulations, which you've seen previously tonight, but I haven't really talked about them. That's where CSF is reabsorbed into the superior sagittal sinus here. Okay. Here we distinguish between communicating hydrocephalus, where CSF can get into the subarachnoid space, but it's not getting reabsorbed, or non-communicating hydrocephalus, where you can have obstructions. Like you can have an obstruction of the cerebral aqueduct, for example, and it causes a buildup of CSF that can't get through. And so you can have an increase in the size of the lateral ventricles in the third ventricle. And it's pretty alarming.
Can you surgically remove these obstructions or put a valve that drains CSF?
A shunt.
Possible?
Yeah, that's what they do. They put in a shunt, a little tube that drains CSF, and then it goes under the skin and usually drains down into the abdomen. So let's do this clinical vignette quickly and finish up. So a 40-year-old right-handed lady presents with worsening bifrontal headaches over 3 months. The headaches are worse in the mornings, but can occur any time of day. Over the past 4 weeks, she's had 3 fainting spells and complains of intermittent diplopia, double vision, right? And unsteadiness of gait. Her husband's noticed some shakiness in her hands over the past months. Her past medical history is remarkable for meningitis at age 7 and headaches since puberty, although less severe. The rest of her medical history is unremarkable. Neurological exam reveals diplopia on lateral gaze to the right and left. And the motor exam was normal with no evidence of an upper motor neuron pattern of weakness. Sensation was intact to all modalities, but coordination was decreased in upper and lower extremities with decreasing rapid alternating movements. Remember dysdiadochokinesia? And bilateral intention tremor. Remember that? That's a cerebellar sign. Bilateral intention tremor was noted on nose finger testing. Gait was moderately ataxic. Tandem gait was not possible. These are all kind of cerebellar signs. Diagnosis, hydrocephalus. Might have done some imaging and such. But when there's an increase in CSF, there's considerable distortion or stretching of the brain, and signs and symptoms depend on where specifically this occurs. So you can have a variety of signs and symptoms. Headache is common. Various cranial nerve palsies are common. Diplopia, therefore, would be common. Going forward, here is a normal brain at 2 different levels and a transverse view, of course, anterior, posterior. And look at this brain with severe hydrocephalus. Holy cow, that is a sick brain. That is really alarming. Going forward, oh, this is just a bit on NPH or normal pressure hydrocephalus. You can read that on your own. It's italicized, which means I copy pasted it from this source. So you can go there and look at that. Here's a gliosis of the cerebral aqueduct. It should be much larger than that. So it's been narrowed, or we call that, that's a stenosis. You could call it, that's a narrowing of the cerebral aqueduct. That's resulting in a non-communicating hydrocephalus. Here's another example of a non-communicating hydrocephalus. That's a tumor right there in this transverse view, anterior, posterior, and it's the same brain. Look at how huge the ventricles are, just blown out, enormous. So that, you know, CSF built up and increased the pressure, and the ventricles were pushed out, enlarged, distorted as a result. This is an example of hydrocephalus ex vacuo. We've actually seen that previously this semester, but it's when you have an increase in CSF due to tissue loss. So this brain is generally atrophied. You can see it around here. By now, you probably noticed that that's not a healthy brain in this coronal section. That doesn't look right. And so there's a lot of tissue loss, a lot of gray matter loss, concomitant white matter loss. And so the lateral ventricles are enormous. The third ventricle should just be a slit, but it's huge here. It's just blown out. And what else did I have for you? I had, that's it. I'm done for the semester. Thanks, folks. Seriously, thanks for taking my class. Thanks for hanging with me through this whole COVID chaos. Thank you, Aaron. And have a happy and healthy summer. And I'm sad. I'm sorry that the semester is over. I'm sorry to let you go. Thanks, folks.
My Thursdays aren't going to be the same.
I know.
How are we supposed to take a test now? It's so sad.
So weird. I hate it.
Aw.
Just keep teaching us. We'll just come back every Thursday.
Yeah.
Just tell us random things that we're going to just eat up.
Yeah, you could be like a host and just show us dissections.
Yeah, just show us
For the podcast.
Be happy.
Yeah.
surgeries, procedures.
You can narrate.
Drew,
We'll just be a club. I love
Drew,
it.
have you ever
I would totally
thought
join.
of doing a YouTube channel?
You know, I was thinking about uploading some of these lectures to YouTube. Maybe this one. Maybe I could upload this one if that's okay.
You
You can do like the Facebook Live meet your fans thing.
Yeah, you could do it like a Twitch thing. Yeah. Every Thursday, I'm going to have decaf Earl Grey now.
Thank you.
Yes, I love that. Oh.
Awesome. Thanks. You're saying such nice things and such nice comments in the chat. Thank you so much, folks. Seriously, I really appreciate it. You make this possible, and you've been great students, and I just really, really do sincerely appreciate it. Thank you so much.